Hi, my name is Connie Clarnis and you're watching the video on binocular visual acuity. Binocular visual acuity is also termed in some instances as controlled binocular acuity. And essentially it's the measure of the level of visual acuity obtained whilst BSV is maintained. So whilst the term itself, binocular visual acuity, you may be inclined to think it's the measurement of visual acuity with both eyes open, it's not. It is the maximum visual acuity that a patient can achieve whilst keeping their eyes straight and maintaining BSV. So whilst both eyes open, the patient may have 6/6 visual acuity. It might be that at 6/12, the patient actually stops maintaining BSV and becomes, say, exotropic. So for 6/60 they're straight, for 6/24 they're straight, for 6/18 they're straight, at 6/12 they break down into an exotrope. Okay, so we're talking about the relationship between visual acuity and the strabismus. And so in doing this, what we're measuring is the control of a deviation. And where we're talking about the control of the deviation, the sorts of patients we're interested in measuring the binocular visual acuity is patients with intermittent strabismus, or patients with latent deviations who have slow recovery, which again, these are the patients who might be either intermittently manifest or who are struggling to control their deviation, are likely to have symptoms or present to your clinic with symptoms. So the information that we're gaining by looking at binocular visual acuity is we're gaining information about the relative fusional vergences. Remember, when we're talking about relative fusional vergences, we're talking about the relationship between accommodation and vergence. And so as the patient is looking down the chart, we're actually putting demands on the patient in relation to their accommodation. And what we're seeing is what's happening to their strabismus as we require more and more demand on their accommodation. Okay, how do we perform binocular visual acuity? Well, the first thing you need to know is what is the visual acuity of each eye. And this is simply needed because in terms of when you're assessing binocular visual acuity, you need to know what is the maximum potential of the patient. So you need to know the acuity of the better seeing eye, because both eyes open, the patient should be able to see down the chart to that level. So the example here I have in the PowerPoint is that if the VA of the better eye is 6/9, well then the patient's maximum capacity for binocular visual acuity will be 6/9. You can't expect that the patient can get beyond 6/9 and have straight eyes at 6/6. They can't see the 6/6 line. Okay, so firstly we just need to do visual acuity of either eye and know what the better seeing eye has, or what the visual acuity of the better seeing eye is, I should say. Alright, now for binocular visual acuity, so for the assessment of the control of the deviation, what we do is we ask the patient to read the decreasing print size with both eyes open. And you observe them. And what you're observing is the alignment of the eyes. So if we take a look at the image here to the right, what we'd be asking the patient is to look at the distance chart and to start off at the very top at 6/60. And you as the clinician will observe the patient's eyes. So let's say at this stage the eyes are aligned and the patient looks straight. Then you ask them to continue reading down the chart, reading decreasing print size continually. And you continue to observe and observe and observe until you notice that the eye breaks away and the patient can no longer control the deviation. They become, or you notice a manifest deviation. That might be an esotropia or an exotropia, whatever it is that that patient is trying to control. It breaks down and you notice it now being manifest. So what we're doing is we're documenting the smallest print that the patient can read whilst maintaining binocular vision. You can also do this at near, and you'll start off with a big print and move your way down to the smaller print, again indicating at what point the patient could no longer maintain binocular single vision. So one way is to observe the patient, where you simply are observing the patient's eyes until you notice that the patient now has a manifest deviation. Now, when the patient becomes manifest, if you're unsure as to whether the patient has broken down, and this is usually when the patient breaks down to a small angle strabismus and it's not very clear to you whether that has occurred or hasn't occurred, you can introduce a cover test. The issue though with the cover test is it's dissociative, and by introducing a cover you may actually break the patient down and make them exotropic or esotropic, in which case you've now interrupted binocular visual acuity testing, and it may not be that the patient has broken down due to accommodative duress that you're trying to elicit through getting them to read down the chart, but rather because of the cover test. So when you cover test a patient, or if you choose to cover test a patient during binocular visual acuity, you have to be very careful. It needs to be very quick and only utilised as confirmation that the patient has broken down. Okay, and if you can avoid it, avoid it. So just use your observation as the guide. An alternative is to utilise the patient's subjective response as an indicator of whether the patient is binocular or where they have broken down. And the way we do this is we use physiological diplopia. In this instance, what we do is we get the patient to look in the distance at the distance chart, but we'd also ask her to hold up, say for instance, a pen, and whilst looking into the distance to tell us whether the pen was 1 or 2. And if the patient is binocular, then they should experience physiological diplopia. Remember, going back to your previous studies around binocular vision, physiological diplopia is a normal phenomenon and occurs when a patient does have binocular single vision. So what should happen is that as the patient reads down the chart, when they become manifest, one of two things is going to happen. Either the chart at the end of the room that they're looking at will become diplopic, or, as is often the case, the patient will become manifest and have suppression, which means that the pen will now become 1 because they've lost BSV. So they lose the physiological diplopia. So physiological diplopia is being used as the guide to whether the patient is binocular versus now they've broken it down. And I encourage you to use physiological diplopia as a guide during BVA testing, but it is a test that can really only be used in older children and then adults. The younger a child is, you're going to have to rely on your objective observation of the patient, and the older the individual is, then you can actually incorporate a subjective response from the patient. In terms of recording, we record the visual acuity where the patient last had BSV. So we don't actually record the break, we record the last or the minimum level of visual acuity where the patient was still maintaining BSV. So in this example, 612 was the last time that the patient had BSV, and the patient had BSV up to N5 or maintained BSV up to N5. So if we look at this individual, this child who is intermittent, we have straight eyes here and an XT here, then what we're saying is that if you were to assess this child at near, they were able to keep their eyes aligned all the way to N5 print. But with distance chart, the child was only able to keep their eyes aligned up to 612, and then on the following line they became exotropic like this. Okay, how do we interpret binocular visual acuity? In order to understand binocular visual acuity, we have to go back to understanding the relationship between accommodation and convergence. Now, you'll recall that as you increase accommodation, you'll increase accommodative convergence. So you can understand that as a patient increases their accommodation, if they have an underlying ESO deviation, it will get worse. Because an increase in accommodation means an increase in accommodative convergence, which means an ET will become worse. However, if you have an exo deviation, then the exo deviation will become better because you're actually converging the eyes more upon accommodation. Okay, and the alternative here we have is when we're decreasing our accommodation, we're going to have a decrease in accommodative convergence, and therefore an esotropia will improve through a decrease in accommodation. Exotropia will worsen. So given this relationship between accommodation or accommodative convergence and strabismus, it's conceivable that patients may try to manipulate their accommodation to try and control their deviation. Or alternative, that their accommodative effort is impacting on the strabismus. So as examples here to the side, I've given you the case scenario of an exotropia. And I've asked you, what will a patient want to do with their accommodation to assist control? So say I'm a patient who has an intermittent exotropia. I'm looking into the distance and I can feel my eye drifting out and I want to bring it in. What I will do is try to exert extra accommodation in order to utilise accommodative convergence to bring that eye in. But it will be at the expense of my visual acuity because I am doing excess accommodation that I shouldn't need to be doing at that particular distance, but I'm doing it so that I can gain control over the exo deviation. Okay, so where a patient is trying to excessively accommodate to bring the eye in an exo deviation, we're going to get a reduction in visual acuity. As another example, if I was an esotrope, then what I'll want to do to control the deviation is relax my accommodation so I get less accommodative convergence and therefore have a better control of my ESO deviation. But again, if I'm doing less accommodation than required, well, the image is going to be blurry because I need to accommodate to see. So you can see this relationship between now not only accommodative convergence and strabismus, but now we have an impact on visual acuity when we're trying to do excessive amounts of accommodation or we're trying to relax our accommodation to benefit the strabismus. We do so, or the patient does so, at the expense of visual acuity in some instances. The only way we can achieve control of the deviation without the expense to visual acuity is if we have good relative fusional divergences. If you can manipulate the relationship between accommodation and vergence, then you have a chance at controlling the deviation without impacting on your visual acuity. Which is where we come back to binocular visual acuity is a way of assessing relative fusional divergences. Let's take a look at a few examples to try and better understand binocular visual acuity. Here we have that same patient where we have an intermittent exotropia. Sometimes the patient is aligned and sometimes the patient is not. So here we would have an exophoria and here we have an exotropia. The visual acuity is 6, 6, 6, 6 and 5 and 5. And on cover test we see that the exophoria at near is well controlled and is small. But in the distance, the patient breaks down to an exotropia of 25 diopters. When BVA is performed, the BVA we can see is reduced in the distance because it's 618 and our expectation is that both eyes open, they should be able to see right down to 6, 6. But what's happening here is that 618 is the last point that they can maintain BSV. At the next level, they're exotropic. At near, they're N5, so there's no issue with BVA. So let's focus on this 618. Why is it that the patient has a reduced BVA? So this BVA is indicating that 618 was the last time that they were binocular, and at the 612 level, they became XT. What this means is that at 612, in order for this patient to have remained binocular, they would have needed to exert additional accommodation to keep their eyes straight. So here I've asked you the question, what will the patient need to do to their accommodation to control the deviation? They need to exert accommodative convergence. So for this patient, they can only get down to 618 before they need to start manipulating accommodation to gain control. Now, the only way for this patient to be able to stay straight up to 6.6 now is to improve their relative fusional divergences, and specifically to improve their positive relative fusional divergences. So what you need this patient to do is to learn how to make a vergence movement in excess of their accommodation. They can learn to see the 612 line, but make a convergence movement in excess of the accommodation required at 612 and gain control over the deviation at that level, and then so on and so forth. So at 6.9, at 6.7.5, at 6.6. Okay, let's look at one more example of an esotrope. So here again we have a patient with good VA, an intermittent ET at near, and esophoria in the distance. And what we see is that BVA is fine in the distance, but at near it is reduced. Okay, we have additional information here that the patient also has a refractive error of +2 and it's been uncorrected. So whilst you're testing BVA, the patient has uncorrected 2 diopters worth of hypermetropia. All right, so I'll ask you the question here, what will the patient need to do to their accommodation to see clearly? So let's say again, this patient is looking at a target at 1/3 of a metre. And at 1/3 of a metre, we know that the patient needs to do 3 diopters of accommodation. Now, if this patient is 2 diopters hypermetropic, they need to do 3 + 2. So 5 diopters of accommodation. So in order for them to see clearly at 1/3 of a metre, you're asking them to do 5 diopters of accommodation, which is more than an emmetrope. And for this patient, it leads to an esotropia. And so when we see N10 in this particular patient, what's happening is that it's only up to N10 that the patient can maintain binocular single vision without exerting extra amounts of accommodation. And at the next level, we've now got the issue where the patient is exerting accommodation to see clearly, which is now at the expense of the control. So in order for this patient to improve, or if we want to try and assist this patient to take control, we need to assist this patient with negative relative fusional divergences. We need to teach this patient how to accommodate in excess of their vergence. So we want to relax their vergence system in relation to accommodation. And if we can achieve that, then potentially the patient can get to N5 while still maintaining BSV. Okay, that brings us to the conclusion of this video. Thank you for watching.